Crohn's versus ulcerative colitis. Let's be real. If you're studying for the NCLEX, you know this is the classic pair that trips everybody up. But what if you could just get it right every single time? Well, in this explainer, we are going to make the differences so incredibly clear, you'll wonder why you ever mixed them up in the first place.
So here's our game plan. First, we're going to look at what these two have in common. Then we'll get into the good stuff, the key differences in their anatomy, the symptoms you'll see in your patients, and how we actually manage them. And of course, we'll wrap it all up with a lightning-fast review to make sure it all sticks.
This is it. This is the big question, right? You've got a patient with chronic GI inflammation, but which one is it, Crohn's or colitis? Everything we're about to cover is designed to give you the clues you need to solve this puzzle with absolute confidence.
Okay, first things first. Before we can start picking them apart, we need to understand what brings them together. Let's start on that common ground.
So both of these conditions live under this big umbrella called inflammatory bowel disease, or IBD. And the key word is right there in the name, inflammation. But, and this is the critical point, it's the where and the how, meaning where is the inflammation located and how is it patterned that splits this one family into two very, very different diseases.
All right, let's dig into the anatomy, because this is where the differences really start to pop. We're asking two really simple questions here. Where in the body does the disease show up, and just how deep into the tissue does it go?
Okay, check this out. Think of Crohn's disease as a world traveler. It can show up literally anywhere in the GI tract, all the way from the mouth to the anus. Ulcerative colitis, on the other hand, it's a total homebody. It only ever affects the colon, and it always starts down in the rectum and just climbs its way up in one solid, continuous block.
And that brings us to a massive NCLEX clue. Because Crohn's can be anywhere, it creates these things called skip lesions. You get these little patches of diseased tissue right next to perfectly healthy tissue. It's patchy. So if you're reading a question and you see the word skip lesions, your brain needs to immediately just yell Crohn's.
Now for that second clue, depth. Crohn's is what we call transmural, which is a fancy way of saying the inflammation punches through all the layers of the bowel wall. This is exactly why it causes those deep, nasty complications like fistulas. Now compare that to UC, which is much more superficial. It just hangs out in the inner lining, the mucosa. That's why it's famous for causing ulcers and bleeding. See, the depth directly explains their unique complications.
Okay, so we've looked inside the body. Now let's talk about what you, as the nurse, are actually going to see and hear. What are the clinical clues your patient is going to give you? With a Crohn's patient, you're often going to hear about chronic diarrhea that is not bloody and pain over on the right lower side of their abdomen. And remember how Crohn's can hit the small intestine? Well, that's where we absorb our nutrients, so it makes total sense that you see major weight loss and those fatty stools, what we call steatorrhea. Now let's flip the coin to ulcerative colitis, and bam, right away, the number one sign, bloody diarrhea. The pain for these patients is usually on the left lower side. And because all that inflammation is concentrated in the colon and rectum, they feel this constant, intense urgency to go to the bathroom. And the long-term dangers are really serious, like toxic megacolon and a much higher risk for colon cancer. Seriously, if you only remember one single thing from this whole section, make it this. For your exams, for your clinicals, for everything. Bloody stool is the absolute hallmark sign that points straight to ulcerative colitis. It's the most important clue you'll get. So we know how to tell them apart, but what do we do about them? This next part is all about the treatment plans and the very different dangers that can pop up for these patients down the road. You know, it's kind of funny. For two diseases that are so different, a lot of the day-to-day management is almost identical. For both, we use things like anti-inflammatories and immunosuppressants to calm everything down. And the diet goals are the same too. Low residue to not irritate the bowel, but packed with protein and calories to prevent malnutrition. But when we talk about surgery, they are from different planets. And this is a huge point for your exams. For Crohn's, surgery is not a cure. You can remove a piece of the bowel, but since the disease can pop up anywhere, it'll probably just come back somewhere else. But for UC, surgery is a cure. Remember, it only lives in the colon. So if you take out the colon, you've taken out the disease. Game over.
And this slide just ties it all together perfectly. It all makes sense, right? The deep, transmural nature of Crohn's leads to those deep problems like fistulas and abscesses. And the superficial, ulcerating nature of UC, which is stuck in the colon, leads to things like toxic megacolon and, of course, that higher risk of colorectal cancer. The anatomy truly dictates the danger.
Phew, we have covered a lot of ground, so let's pull it all together in one last super fast summary. This is your 30-second recap to just burn these facts into your memory for exam day. Let's lock this in. Ready? Location, Crohn's is anywhere. UC is colon only. Pattern, Crohn's has patchy skip lesions. UC is one continuous block. Depth, Crohn is deep and transmural. UC is superficial and mucosal. Stool, Crohn's is fatty. UC is bloody. And the big one, surgical cure, that's a no for Crohn's and an absolute yes for UC. You master this table, you have mastered the difference. Period.
Need a little trick to remember the complications? Try this. Crohn's creates cracks. Those cracks are those deep fistulas and fissures that tunnel right through the bowel wall, all because that inflammation is transmural. And for ulcerative colitis, it's even easier. Just remember UC. The U stands for the ulcers that cause all that bleeding, and the C stands for the increased risk of colon cancer. Simple, right?
So, I'll leave you with this question. After breaking it all down, from the skip lesions to the bloody stool to whether surgery is a cure, which of these clues is the one that really clicked for you? The one that's going to stick in your head? Find that one anchor point, and I promise you'll be able to rebuild this whole picture anytime you need to.